year-old man whom I first saw a few years ago. And in August, he developed episodes of a cold feeling in his chest for 10 to 20 seconds. And over the actually it started in July, end of July, and over the course of the month of August to early September, this went from happening once every couple of days to daily to several per day. There were no associated movements of any kind, preserved awareness, but he just had this stereotyped cold feeling in his chest for that brief period of time. He was referred to a neurologist who thought these are stereotyped episodes. I will give this man an anti-epileptic, and she prescribed lacosamide at a dose of 150 milligrams twice daily, and the symptoms stopped completely. He was better. She had obtained an EEG, which was normal indirectly, and she had also obtained an MRI scan, which was normal, I'll mention. He was good for about 2 weeks, and then he developed symptoms, and I'll show you. And these were happening many times a day. So this is a video of him. I will let it go. Actually, this will be first. And that was it. I'll go back. I'll let you watch that, and I'll show you another example. Okay. That's the southbound side of me heading northward. Here it is, and here's another example. Oh, and that was it. Again, I'll go back, watch again. So his interictal EEG is normal. He was on our monitoring unit. The EEG running during this was completely normal. As I said earlier, his MRI was normal. Describe the symptoms for me. What do you think this is? Some people want to offer some opinions as to what they think that behavior is. And some on the conference will know me. They will know me well enough to know that it could be a seizure. It might well not be a seizure. Would anyone like to offer an opinion?
There's a couple, if you open the chat, Mike, there are some coming through the chat too.
Open the chat. I'm looking for the chat.
In the bottom control panel, or up at the top for you.
Yeah, it's probably up at the top here or more. No, I don't see, it's funny, the chat is not appearing.
It's in the more menu, it should be.
Okay, Q&A is different than chat. In the more menu, oh, I see, here's chat, okay. So we have a number of opinions, people are chatting. Let me see. First, it's a lot of people not being able to hear. Myoclonic jerk, dyskinesia, dystonia, either epileptic or non-epileptic. Someone says insula, possibly seizure, maybe bilateral asymmetric brief clonic myoclonic, focal aware, paroxysmal kinesiogenic dystonia. So we have a number of opinions being offered. What I'll do right now is first we'll take a poll, and you should all be able to see this now, correct? Christina, we can see it?
Yes.
Good. So I've launched it. Start polling. Click on either yes or no if you think it's a seizure. Okay, so some people are fairly convinced that it's a seizure. We have 45 out of 51 thus far, 6 out of now 46 out of 52. It looks like everybody's voted. We have 52 people on, and 46 of the 52, so nearly 90% of you think that it's a seizure. Okay, so I'm going to put up another question, just again, here, again, for those of you who think a seizure, you've got a couple of choices in there, and for those who don't think it's a seizure, you have some choices. So we have REM behavior disorder, Meji's syndrome, faciobrachial dystonic seizures, tic disorders, or seizures of juvenile myoclonic epilepsy as our choices. And 92% of the people thus far, 90% are saying faciobrachial dystonic seizures. We have about 8% saying myoclonus, Meji's syndrome, tic disorder, and those are our choices. So we'll end the polling. For now, I'll close that. And what diagnostic test would you order? So let's come to that. So let me move forward. So we got some diagnostic tests, and prolonged EEG was suggested, but the real test, as you can see on the screen, is autoantibodies, because this is about as classic an example as you'll get of faciobrachial dystonic seizures. And as most of you probably know, this is seen with what was originally described as voltage-gated potassium channel antibodies, and we know really that it's not exactly that. There are two subtypes, the LGI1 and Casper2, with the definitions below at the bottom of the screen. And in this patient's case, his antibody was 485. It was with normal being less than 80 in both serum and CSF. So you can get a serum test and CSF. CSF is a bit more sensitive. And most importantly, he fits the clinical picture. Adult onset, sudden, rapid, the behavior is faciobrachial dystonic, and those people have antibodies, typically to LGO1 or Casper2. So all antibodies are negative, so this is clearly an autoimmune epilepsy, and then how are we going to treat him and how are we going to diagnose him? So let me move forward. There are some scores that have been proposed. There was the APE score, APE, and the RITE, RITE. This was proposed by the group at the Mayo Clinic, with Dubey being the primary author in a number of the papers, or first author. And Dr. Dubey has now recently, you can see this is from an article in Neurotherapeutics last year. The article, I believe, is less than a year old. Now has the APE2 and the RITE2 because he added and encephalopathy to epilepsy. So it's the antibody prevalence in epilepsy was APE and encephalopathy. There are two E's. And the RITE2, same thing. The last E, there are now two of them. It's a scoring system where you can see the symptoms, and you've got the reference down there, so you can all go home and take it. Anybody who wants to take a screenshot and save it, you can do so. Neurotherapeutics 2019. And you can see that the two scores are basically identical for the start. There's not any difference from the first left side to the right side initially, but then as you get near the bottom on the right score, there are a couple of other categories. And these are basically the features of autoimmune epilepsy and encephalopathy. You can see rapidly progressive mental status changes over 1 to 6 weeks, and or new onset seizure activity. And if we drop down a little bit, you can see my screen. We drop down about 6 or 7, you see seizures refractory to at least 2 anti-seizure medications. So new onset seizures that don't respond, and that buys you 2 points plus 1 is 3. Are there neuropsychiatric changes? Is there autonomic dysfunction? Was there a viral prodrome? Faciobrachial dystonic seizures gives you a +3. That's a very specific symptom. So you can see new onset seizures, and if they're faciobrachial dystonic, you have 4 already. If they're not responsive, you're up to 6. +2 here. And in fact, this fellow, I could show you in other videos, had some facial dyskinesias as well. He often had this incidental grimacing at the time. We can look at a couple of other signs here. Brain MRI imaging suggesting encephalitis. Has there been a systemic cancer, which add a little bit more? This gives you a total of 18 points maximum on the, and the antibody score, the antibody prevalence scores for diagnosis, the response to immunotherapy. So this is, will they respond to treatment? You can add a little bit more. Did you get it within 6 months? If the patient came in to you and symptoms have been present for a longer period of time, you don't get those points, and they're less likely to respond. And then is it a plasma membrane autoantibody? So this is the list of the plasma membrane autoantibodies: MBA, GABA-A, GABA-B receptor, AMPA, and you can see the list there, of which LGI1 and Casper2 are there. And as you recall, our patient was LGI1 positive, not Casper2, and that's the usual case. so that you can buy an extra 4 points with that. How do we use those? If you have an APE-2 score of 4 or greater, the sensitivity is 98% and the specificity is 85%. Meaning what? Highly likely to detect it, but not all positive antibodies are negative. And there are lots of series published around the world where, in the general population, a few percent of patients, of people have antibodies with no symptoms. If you have a score of 7 or greater, the specificity is 100% though. So having an antibody is not great, but if you fit the other characteristics on the APE-2 score and add up to 7 points, it's 100% specificity. So you then eliminate your false negative. The right 2 score for treatment, if you're at 7 or greater, you have a sensitivity of 88% and a specificity of 84%. So then nothing is perfect. Nothing in life is perfect after all, right? Any questions or comments? Okay, so how are we going to treat this person? Do you think anti-epileptic drugs are appropriate? What would you first prescribe? Let's do a poll first. Poll 3. We'll launch it. You've got 4 choices. Anticonvulsant drug first, which this fellow has had and isn't working. Steroids, IVIG, or L-Dopa, carbidopa for his dyskinesias. So I guess you can all see on the list, it looks like more than 51, not everybody's voting. It's going up, 53, 54, 56. Okay, so it looks like steroids and IVIG are pretty close, with 32 people voting for steroids, 25 for IVIG, and 6 going for anticonvulsants. Okay, good. I'll move forward. This was a nice study. It's not so new anymore. It was published by the British group, by Irani, who was, I think, was either at Cambridge or Oxford, I forget which, in the UK. Published an interesting paper in the Annals of Neurology 9 years ago, which basically the punchline is my title slide: LGI-1 response to immunotherapy, not anti-epileptic drugs. The facio-brachydystonic seizures often precede the limbic encephalitis. You can see the frequency in these cases, 50 per day, which our patient has. They're typically less than 3 seconds. They're dystonic. They may be triggered by auditory stimuli or emotion. And EEG is all over the board. EEG is completely useless here. Kind of like we are during a COVID epidemic, I think, for this. But you can see the graph from Irani's paper, response to AEDs, rash adverse event, 40% of patients, nil to little response, 80% good or excellent response to AEDs, practically no patients. Whereas immunotherapy, good or excellent response in the majority of the patients, and only a small proportion did not respond. Any questions or comments? Okay, so what do we have here? And I'll finish this didactic, we'll get to the next case. Just recently, within the past couple of months, a paper came out in the Annals of Neurology, also from the Mayo Group. They wanted to recruit 30 patients in a randomized double-blind controlled trial, placebo-controlled trial, and randomize these 30 patients to either immunotherapy or placebo to see what would happen. After 34 months, they gave up the trial. They could only get 17 patients. And the reason is that everybody was treating their patients. They just didn't see the need. It's kind of like using a parachute, jumping out of an airplane. You don't really need to do a randomized trial. It's fairly obvious, and nobody's going to jump out of a plane without a parachute to prove it, right? Although those of you who may remember, there was a paper in either JAMA or the New England Journal, which was a randomized controlled trial of parachutes jumping from planes, and they found it was equal. And I would encourage you all to look that up. That paper came out a year or two ago. It showed the deficits of a randomized trial, but showed that parachutes saved no more lives than not wearing a parachute jumping out of a plane. So in this study, however, they showed very plainly that the responder rate for IVIG in blue, placebo in red, was rather striking, and there's a difference. Again, some people have something of a response, stable or improved, but really seizure freedom, responder rate, a whole lot better. And then when you took people after the first 5 weeks and gave them IVIG, they improved. to a significant extent, with in the case of 1, 2, 3, 4 out of 6. So there was a suggestion that they had to stop it at 5 weeks, not a suggestion because they ethically felt they couldn't go any longer. But you see greater than 50% reduction in 6 of 8 patients with IVIG versus only 2 of 9 treated with placebo. There is no randomized trial comparing steroids, plasma exchange, or IVIG. This is the only randomized trial that exists for this condition, for the autoimmune epilepsies and LGI1, Casper2 in particular. It's a question that someone just asked. What is the appropriate therapy then? And it's interesting, while the Mayo group randomized people to IVIG or placebo, if you talk to them, they still tend to use steroids first. And in conversations that I've had with Joseph Dalmau, and also who's in Barcelona, and Christian Bean in Germany, and I think the group at Oxford with Angela Vincent and Ronnie's group too, they tend more often to use steroids than IVIG, though both are acceptable. And Plex is an option as well. So with the IV methylprednisolone, 1,000 milligrams a day for 3 days and weekly for 5 weeks, and then sometimes they might extend it bi-weekly for another 6 weeks. Or IVIG for 3 days, 0.4 milligrams per kilogram, and then weekly for 6 weeks, and then they may extend it as well. And obviously Plex is for people who can't have the others. There's a tendency for many people to very early go to rituximab or cyclophosphamide, with preference for rituximab first, right when you get it started. So they come in, they get the immunotherapy, and then ideally they get the rituximab once insurance approves it, which takes 1 or 2 weeks. None of this is placebo-controlled. Nobody has done good randomized trials of all of these, and this is all based on personal experience. And we're, I think, all in a situation of having to have faith in some of the larger centers that have treated large numbers of people, which would be the groups in Barcelona and Mayo in Germany. Comments, questions? Okay, let's move to another case. This is a different kind of a challenge. 28-year-old woman who's had a history of tonic-clonic seizures starting at age 17. Seizures begin with a sudden loss of consciousness without aura. She has bilateral tonic and then clonic movement, last a minute or two according to her husband. Seizures typically occur within half an hour of awakening. I guess on the chat, what's your diagnosis? And I guess I'll answer, somebody has had, shouldn't IVIG be 0.4 grams per kilogram? Yes is the answer. I guess there was a typo in that slide. It should be 0.4 grams. It's 400 milligrams per kilogram. So diagnosis JME has been offered for this case. There's no history of myoclonus, so I would say you can't diagnose JME without myoclonus. IgE, yes. So there are 4 IgE syndromes, one of which is JME, one of which is childhood absence, one of which is juvenile absence, and the last one somebody wrote is IgE with generalized tonic-clonic awakening. So this is one of the 4 well-defined syndromes. And again, could our diagnosis change? Might this person starting at age 17 first notice myoclonus at 19? You might change your diagnosis, but in her case, it hasn't happened. So that's the diagnosis, tonic-clonic on waking, one of the classic idiopathic generalized epilepsy syndromes. And what's her EEG going to show? I think we all know it's going to show generalized spike wave at 3 or 4 hertz. Now, in this case, at age 17, when her seizure started, she started to take lamotrigine. She had a reasonable dose, and she was having 2 or 3 seizures a year. After 3 years, she was switched to levetiracetam, and she still had 2 or 3 or 4 seizures a year over the next couple of years. Again, up to a decent dose. And then at age 22, she was placed on valproate, 500 milligrams per day, and seizures stopped cold. No seizures for 4 years. At the age of 26, she saw a new doctor who said, "You're a young woman of childbearing age. You should not be on valproate in case you get pregnant." And he switched her to oxcarbazepine because of concerns about teratogenicity. And wouldn't you know it, seizures came back at a rate of about 2 or 3 per year. She has no epilepsy risk factors, family history is negative, her exam's normal. I told you what the EEG would show, and that's exactly what it showed. Her MRI is normal, but now she comes to you she's not so happy with this doctor who put her on a drug that gave her her seizures back, and said, you know, I got married last year. We would like to start a family pretty soon. What do I do? How would you manage her? And I will put up a poll with a few choices. I have to go to question 4, and we'll relaunch the poll. So I've given you a few choices. One is continue the oxcarbazepine. Another would be taper it and go back to valproate because she took that and she was seizure-free at 500 milligrams a day. Another was taper it and put her on lacosamide. Another one is, well, add perampanel to oxcarbazepine. After all, that has been approved. Has an approved indication for idiopathic generalized epilepsy. There's data there. And then there's the other. So what are people saying? So we're getting some votes. Okay. So one person said zonisamide. Another person said, why not Keppra or lamotrigine, levetiracetam or lamotrigine? But I can tell you she's already failed those 2 drugs. Those were the first 2 drugs that she took, and she had seizures on those. So she won't agree to go on those. She's the same as on oxcarb as she was on lamotrigine or levetiracetam. Somebody else says lamotrigine, but again, she had seizures on lamotrigine. So I think we'll close the poll. We're at 56, and it looks like we have continuing oxcarb is 3 people, 5%. 10 out of 56 had taper and start valproate. Taper oxcarb, start lacosamide for 15, add perampanel 4, other 25. So we'll end the polling there. Those are our results. Other wins. So there are a number of things we can do. And what are the considerations that we have here? What do we want to do? Anybody want to say anything? You can unmute yourselves and speak.
Sodium channel, the anti-epileptic that work on the sodium channel can make the generalized epilepsy worse.
I'm sorry, say that again?
So the anti-epileptic medication that work through the sodium channel can make the generalized epilepsy worse. So we may have to reduce that oxcarbazepine and try to have start something else.
Such as?
Which is, I actually missed, if I can see what are the previous drugs used.
She's had oxcarbazepine, levetiracetam, and lamotrigine.
So we do have option of lacosamide, Vimpat, which is a broad acting. We have other options of like perampanel is also an option, but we don't know about the safety on pregnancy.
Yeah, so there are a number. I mean, lacosamide was one of our more popular choices. There is some data on lacosamide in pregnancy. It looks to be probably about the same as levetiracetam and lamotrigine in the studies, but the numbers are not huge. The last paper I saw, there was one with about 38 patients from a few years ago. I'm sure there are more. Perampanel safety in pregnancy uncertain, somebody says. Somebody wants to add VNS. You can do that. On the other hand, we have no data about VNS efficacy in this case. Zonisamide, some people like. Lowest effective dose of valproate and perampanel. So let's go to the slide and look at a couple things. So, you know, I have a few options here. Continue oxcarb, try lev or lamotrigine again, but we know she'll seize, we do valproate, or there's a whole variety of drug or polypharmacy. So what are some of the considerations? And one of the considerations is we have a live human sitting in front of us. If this were a male, we would all say we would put this person on valproate. And the person wouldn't have been taken off because and we also know for a fact that valproate works. This woman went for 4 years without a seizure on valproate. On 3 other drugs, she had seizures, right? So we know valproate works in her, and we also know it works at a dose of 500 milligrams per day. And Seda just said valproate 500 milligrams a day, too. So we know it works. What are the risks to her? So this is a big study, and I apologize. I forgot to put the reference on the bottom. I just realized to figure out where this came from. I have the paper sitting on my computer, and maybe we can have it circulated or people can find it. But you can see in a large number of seizures in a lot of patients in a big study. This was from Germany, as I recall. They had 5,680 generalized tonic-clonic seizures, mild and severe. Number of injuries, 22% had mild injuries of these seizures 0.9%. So about 1% of tonic-clonic seizures cause a severe injury, and you can see the odds ratio and confidence interval. So tonic-clonic seizures are bad, we know that. Mild injuries could be bruising, a fracture would be a major injury, hospitalization, some injury leading to obstruction. Complex partial or focal impaired awareness, you can see 0.8% risk had mild injury, and severe only 0.3%. Simple partials, just about never. Myoclonus, incredibly rare. And really the only category with severe injuries is tonic-clonic. I can tell you I have had, thus far this year, 2 patients have fractures from tonic-clonic seizures. One patient fractured a femur, and the other one fractured his humerus. And I had a third patient who did, actually a third patient now that I think of it, this year, fracture his skull and have a subdural from a tonic-clonic seizure. So they're not terribly common, but you're putting this woman at risk. But if you say to her, I want you to keep taking a drug that causes seizure, that we know will not control you fully. Okay. Now, the flip side, what's the risk of birth defect? And we know valproate has a number of them. I could put up a bunch of slides, but this is supposedly a case conference. I don't want to put too many. The incidence of birth defects is a bit higher. Teratogenetic potential is higher. There's some evidence that IQ in babies born to women on valproate is somewhat lower, maybe as much as 8 or 9 points in some studies. One study could not find that. And then this is the other thing that we need to think about, learning disabilities following in utero exposure. And this is the odds ratio, and this is from the paper published by Beck and colleagues in JNNP in 2018. And you can see no AED, which is the reference, odds ratio 0. Odds ratio of 1.99, so really a 2-fold increased risk taking any drug, and then adjusted, it's still 2.2. It's about the same. So about doubles the risk of having a learning disability. And then when we start parceling it out to individual drugs, again, no drug is the reference, you can see 4 drugs are at the far end: valproate, phenobarbital, levetiracetam, and topiramate. But you'll also notice the ends. Lamotrigine, 290 women, or actually kids of women on that drug, 55 with valproate, and then we're really in low digits for phenobarbital and levetiracetam, 11 and 12, topiramate's 27. Oxcarb's a bit higher at 44, 43 for carbamazepine, gabapentin. So these have a slight increased risk, but it's lower. I think the number of subjects having received phenobarbital and levetiracetam is low. It's worrisome, and topiramate, but I don't think we know for sure yet. I think those numbers need to be taken with a grain of salt. But 55 babies or kids at that point, born to women taking valproate, this is a high risk, right? And what's the risk factor? 5-fold higher need for special ed. So I think this is a consideration too. You've got a lady in front of you having tonic-clonic seizures. If you leave her on her present drug, she's having 2 to 4 seizures a year. If you put her back on lamotrigine or lorazepam, she's having 2 to 4 per year. I think based on my personal experience, and I've got many hundreds of patients with idiopathic generalized epilepsy that I've treated, pretty much any other drug you put her on, she'll still have seizures. You could put her on lacosamide, perampanel, the others. The odds of her still having some seizures are going to be pretty high. So the chances of seizure freedom are low. I wouldn't say 0. Maybe she'll respond to perampanel. Maybe she'll respond to lacosamide. But given failure of 3 other drugs, the odds are very small. And we know that valproate works. So here's the other side of the coin. And this is a paper from the Berlin group, actually a follow-up in Dieter Janss's patients with generalized epilepsy that he's been following since 1922, I think. No, but since the 60s or 50s. That Dieter Janss followed. And you can see what proportion of patients, this is absence epilepsy, juvenile myoclonic, epilepsy with generalized tonic-clonic seizures, unwaking or not. Those are the 3 categories they had. And they didn't have childhood absence here. And you can see age at onset, adolescent onset like our patient, mean follow-up 4 decades, age at last seizure in the 40s, age at last tonic-clonic seizure, terminal seizure remission greater than 5 years. You can see 57, 59, 63%, and terminal tonic-clonic seizure remission 71, 67, 63%. So just to show you that these conditions are far from ideal, that while we think of them as benign, only about 2/3 of these patients really have long-term seizure remission. Many still continue to have occasional seizures. And how many are anti-epileptic drug-free? 15%, 18%, 23%. So a relatively small amount. And seizure relapse after discontinuation, pretty high rates. But again, the numbers, you have to be careful. The number of discontinuations is very small, only 3 here, 10 here, and 16 here. So they're conditions that are not perfect, but I would argue that the patients who can go for 3 or 4 or 5 or 6 or 8 or 10 years in between seizures are better off than the lady who's having 2 or 3 or 4 per year. So how to treat this patient. And now there's one other bit of data with valproate that I'll mention. I'll go back a slide. And that is there are a couple of papers suggesting that valproate doses less than 800 milligrams a day are not so bad, and less than 700 a day even better. And in fact, at 500 a day where she is, the risk of cognitive impairment is not quite as certain. There's one paper that says there's still increased risk of learning disability even at a low dose of 500, whereas the teratogenic effects are markedly attenuated. And there's another study that says the cognitive adverse effects are really markedly reduced if they are dose dependent. So I think this is a woman that you have a conversation with, and it's very difficult for all of us. You know, we are sitting in a room with a patient, and I have this life in front of me as opposed to this potential life. And if she has a seizure and dies from it, or has a serious injury, then I feel terrible. If I put her back on valproate and the baby has a problem, I feel terrible. It's no win to a certain extent, or they're individual wins. Put her on valproate, she wins, baby might lose. Don't put her on valproate, she might lose, baby might win. And again, a tonic-clonic seizure in pregnancy puts risk to the patient and the fetus than valproate. So I think this is a conversation you have with the patient, and it's an informed discussion that the patient makes as to where he and she feel most comfortable. I remember once having this very conversation with the patient, with this patient actually, and her husband. She had just gotten married, and this was the first time I met him, and she had been seizure-free for 4 years, which is why I have this case. And he had only been married to her for a few months, and he didn't know yet. So I said, the discussion, what do we do? And instead of being quiet and letting her speak, since it was her health first, and then offering an opinion or being supportive, he instantly jumped in and said, I think we don't want to go back on valproate. And she looked at him, and if daggers could have come out of her eyes or lightning bolts to strike him down, it would have happened right then, because she started to cry. You don't know what it was like to live with seizures. It was horrible. I injured myself a number of times. I get scraped up. It was a scary, horrible thing. And so you have to have these conversations. Now, this woman has one advantage that many people don't have. So unlike the person who has tonic-clonic seizures at any time of day and is unpredictable, her seizures often happen within half an hour of waking. So you could argue that one conversation to have with her is that if she stays on the present oxcarbazepine, or you want to try another drug in the hope that she'd be better, although she could get worse too, she could wake up, husband or somebody else stays with her for the first hour, maybe she wakes up and stays in bed. If she has that seizure, she's about as protected as possible. You might not protect her from SUDEP, right? I mean, you could be awake and have a witness there and still die of SUDEP. It's not as common as dying alone in sleep, but it can happen while awake, and it can happen with other people present. But this is a lady who you might be able to protect and therefore shift to a drug that is safer for developing fetus, and at the same time have her in a situation where maybe you have the most protection possible. So you can be a little creative with these cases. If her seizures happen at any time of day, it's a bit tougher to do.
Mike, we had a question come in through the Q&A.
Yeah, where's that?
From Carolyn. She says, but won't you have to increase the dose in pregnancy?
So won't you have to increase the dose in pregnancy? You may have to increase the dose in pregnancy. This is true. What we normally would recommend doing is establishing what the level is pre-pregnancy, following it carefully. Arguably, what affects the fetus is not how many pills she takes into her mouth, but the level in the system. So if this woman's level, and I'll tell you at 500 milligrams a day, her level's around 35 or so. And that works for some people with this condition. They don't need a lot. You'd be surprised how many people respond to a low dose. You could target, monitor her. Maybe you'd have to get her up to 750 a day. I doubt you'd have to go higher. But you'll have to watch the level and keep the level straight. And it's true, raising the dose, nobody's done good studies of level during pregnancy. Raising the dose might put her at some increased risk, rather a fetus at increased risk. This is, again, one of those situations that is not ideal. But one can be a bit creative, and I think this is where having an informed patient plays a role. I apologize for not seeing the question. I see here's the Q&A. I'll move this over as well so I can see it. Okay, let's go to case 3. And I apologize for an unsatisfying case, but I think you have to think about all these things, and it's a pity that we don't have something better. The good news is that there is a drug under development now that supposedly is close to valproate in structure, should work the same way, but at least in some animal models does not appear to have the teratogenic risk of valproate. We have, of course, every animal is different, so you could have a birth defect in a rabbit but not a mouse, and in a human but not a dog or a rabbit. But it would be nice if in 5 or 6 or 7 years the world is a different place and we have a replacement for valproate. We'll have to wait and see what happens. And then somebody asked the question, at what dose of valproate do you really get worried about teratogenic effects? And I think the answer is over 750 a day. There's good data for teratogenicity, and over 750 is worse, and it's somewhat dose dependent, the higher dose. There's a paper by Mader in the NEEDS group, Kim Mader, M-E-A-D-O-R, where they looked at valproate dose, and clearly in a lower dose, it's better. And there's a group in the UK that have also looked at this. Gus Baker and colleagues have studied this as well. So those are a couple of references that I can cite for you to look at some of the cognitive and teratogenic data. Last case, we'll do it in 15 minutes. 65-year-old man had 2 tonic-clonic seizures in his life. They occurred without warning, sudden loss of consciousness, stiffened and shook, according to witnesses. First occurred at age 56, second at age 58. And he's now 65. I see this gentleman about once a year. He's one of the best dressed people that comes in the office. He usually is wearing a suit because he's a lawyer. And occasionally, if he doesn't have to go to court that day, then he might be dressed more casually, but he usually is well dressed. He was given levetiracetam at a dose of 1,000 milligrams a day after the second seizure, and he had no more seizures since then. So now for the last 7 years, he's been seizure free. Guy's happy as a clam. He's got no risk factors. He's working full time. He's married. He drives. He feels well. Has no side effects from the drugs. His neurological exam is normal. An MRI was normal at the time that this was done. And a follow-up MRI is normal. And he's had a couple of EEGs along the way. And these are normal too. And at this point, I saw him in the office and the question has arisen, does he need to be on medicine still? Can we stop his medication? What would you tell him? And let's do a quick poll first. Would you advise that he stop medication? And this is yes or no. So it's a little even with a few more people saying yes than no, but not everybody has voted. 52, 54, 56, we're at our same 56, 57. I guess I'm doing a reasonable job. Half of you haven't dropped off. Okay, 58. 32 and 26, so a little over half, 55% of you said, yes, I would advise stopping medication. Eric Valenti raised his hand. Eric, you want to speak?
Oh, no, I tried to lower it. My apologies. But I guess while I'm on, I would want to risk stratify him with like a 24-hour ambulatory, or at least have an EEG that captures sleep before I make that decision.
Okay, and Eric, I'll give it to you. You can stay on for a minute. Let's say we do the EEG and it's normal, like his last two.
It's a difficult situation. I would have to discuss with him the benefits and the risks of it. Your chances, he would have I would say that probably would be about a 30%, 40% chance of having a seizure again.
So you've hit a key point there, Eric. So let me ask somebody, We're going to ask everybody, what do you think the chances are of him having another seizure? So again, it's going to be an informed decision. I have several choices: 10%, 25, 45, 65, 85. What are the odds of this fellow having another seizure? So far we have 32 votes. Nobody says 85%. We're mixed among the others. 45. We still have a number of people who haven't voted. Okay, so we have 53, 54. We're going to end polling in 1 second. 55. Okay, so what we have, if three fewer people voted this time, we'd say 10% was guessed by 16% of people. About a third of you, 35%, thought a 25% chance of recurrence. About a quarter thought a 45% chance of recurrence, and a quarter thought a 65%. So this, I think, is an example of at least some of you, and I shouldn't say some of you, most of you having a number, a sense of a number. But where did you get that number from, I would ask you? So what are the risks? So here are some studies, population, and you'll notice the good studies, the best studies really are adults and kids put together. So you have to take it with a grain of salt applying to adults, because kids more often get better than adults. So 25 studies, medically treated patients, published in 1994, a nice meta-analysis. 25% relapse at 1 year, 9% at 2 years. You can see there's a big range, 12 to 67%. Another meta-analysis of adults and kids in 2004, 9 studies, 1,800 patients, 45% risk of relapse. Here's another one, 34%, 31%. I think the best study was published in Lancet Neurology, actually almost exactly 3 years ago. I think it came out in May of 2017 by Herm Lamberink from a group in Holland in the Netherlands. There's a paper and there's a website I'll show you in a minute. It was a meta-analysis. They liked 10 studies, 1,769 patients, median 5.3 years follow-up. And they included prospective, retrospective, and randomized studies. And then somebody else asked, does he have side effects? The answer is no. Somebody says we can try to stop. We don't know if he'll have seizures again. It's his choice. Does he like driving? From Jacqueline. That's a good question. If he lived in Philadelphia, which he does near me, and has to take the Schuylkill Expressway into town every day, he probably does not like to drive. And then Jay Bronder says leave him on. This is the curve you can see from the meta-analysis published by Lamberink, showing you can see at 1 year about 30% of relapse, at 2 years 35%. You get out to 5 years, about 55% are still seizure free, so 45% of relapse, and it drops down so that by the time you're out around 10 years, half have relapsed. And that's an overall curve. What he did, and this is a website you can use, and my fellows have it on their phones. If you just go to epilepsypredictiontools.info, if you just search, do a search on Google or whatever search engine you like, epilepsy prediction tools, you'll find this website. Go to it on your browser and then hit the button to put it on your home screen. I can actually, I don't know if you can see my phone here, but it's right on my home screen on the left, second row from the bottom. So it's an easy thing to do. And then you just fill in the numbers. Duration from first to last seizure, our patient was 2 years. Time since the last seizure, our patient was 7 years. Number of drugs, he's had 1. Age of onset, he was 57 or 55, I forget which. Is male. Family history negative. Febrile seizures, no. How many seizures that he had, 0 to 9 or 10 or more? Is it a self-limiting syndrome, developmental delay? Is it focal? Probably yes. EEG, normal, not performed, or epileptiform, and you click calculate. And you can just do that very easily. And I would encourage you to play with it. And the one thing you want to play with the most is time since last seizure. and take it out really far. Because if you look at I can click on that for a minute, but I have to, with this system, it's a little clumsy, and I won't be able to get through it in time. So if you put that information in for our patient, in fact, his 2-year risk of recurrence is 46%, and the 5-year risk is 57% of a relapse. Now, the chances of him having a year without seizure or a 2-year seizure-free interval is better than 90%, but odds of him relapsing are 46% in the first 2 years. So, you know, if somebody put that question to me and I thought, well, gee, I live in a western suburb of Philadelphia, I have to get in my car and drive to work every day. In fact, if I took the train, it's still a 1.75 mile drive to the train. There's no bus to the train, and the bus is at the same place as the train. It doesn't make a difference. And if I lose my ability to drive, that's a problem. I travel to meetings by myself in normal years frequently. Would I be willing to get on a plane and fly to another city, another country by myself if I were worried that a seizure might happen? You know, what would my wife or my family members think about me just walking up and down a flight of steps? My daughter had a baby last year who just turned a year old. You know, would my daughter feel comfortable with me holding the baby, taking the baby out for a walk, going outside and playing with the baby? You know, is it worth it to me? So if I'm having side effects from the drug, I might say, oh, I don't like this. Maybe I want to come off, or maybe I should. Maybe I as a doctor should have done a better job treating my patient and made sure he didn't have side effects, right? But I think it's up to him. You know, the person who lives in the city who doesn't rely on public transport, who feels safe, may want to say the glass is half full or slightly more than half full. Somebody else might say the glass is half empty. I'd rather not chance it. And if you play with this program, again, epilepsy prediction tools, you'll see it's the one variable that really matters is time since last seizure. You need to get out to 20 years before the number gets low, and it gradually diminishes. But 20 years, 30 years is how far you have to go to get low. Now, what do you advise him about driving? So let's say he wants to stop driving. He wants to stop his medicine. Let's say his risk was 30%. Let's say it was 15 years out, so his risk was 25% even, rather than 7 years out. What would you tell him about driving? So somebody asked the question, does he like driving? Would you, if he's tapering, would you tell him he has to stop driving? And would you tell him he needs to stop driving for a period of time? Or would you still let him drive? And then when do you tell him to stop driving? As soon as you start tapering the drug, or after the taper is complete? And then for how long do you leave him on it? Right, so let's say, you know, a conservative taper would be at least 6 weeks. Some of us might take a bit longer even, but let's say I did a 6-week taper, and then once it stopped, he could certainly relapse. You know, I think if you tell your patients that they're not permitted to drive when you stop the drug and for a period of time afterwards, you've made the decision for most of those patients. They will want to stay on their drug, or they'll come off of it but not tell you about it because they want to drive. If you're going to have them not drive for 3 months or 6 months because you're tapering drug, you know, they'll either lie to you and say they're staying on it and go off of it, or they just won't do it. So you've made the decision for them, right? So how do you advise them? That makes a difference. So here's a study published in the group in the UK by Bonnet and JNNP. And what was the risk? They had 317 patients who they withdrew from medicine. So they, at time 0, there were no seizures. What was the probability of having a seizure in the next 12 months? In the fact, having been seizure-free for at least 2 years at the time of withdrawal. And in fact, in their group, 30% relapsed. This is the confidence interval on the side. At 3 months afterwards, there was still a 15% chance of relapse. 6 months after, there was a 9% chance. 12 months, it was 9%. You can see 18 months, 8%. 24 months, 5%. So the chance of relapse, even 3 months out, is still 15%, which is not tiny. And at time 0, it's a 30% chance. Now let's look at some facts in the US, and there's data from the FHA. I've been online looking at this. The latest I could find for number of trips when I last looked this up, and I last looked this up, I have to be honest, about a year ago, so maybe there's something in the last year, is that number of trips, 63% were under 9 miles. And then you could see 16%, 10 to 19 miles, 20 to 49 miles, 9%, and smaller than that. And less than 1 mile was actually 10%. So Most trips are short. How much time do people spend in the car? Well, if you're on the freeway in Los Angeles, this 8 miles could still be an hour and a half in the car, I suppose, right? Or in New York or Chicago, or in Philadelphia, it would be an hour. How much do people drive, right? So the risk of having a seizure while driving and your decision to say stop driving to a certain extent is going to depend upon how much they drive. The person who drives for a living, is an Uber driver or a taxi driver, and is in the car 8 or 10 or 12 hours a day, has a much different risk than I do, who spend about half an hour each way driving to and from work 5 days a week. And it might be very different than somebody else who, goes out 2 or 3 days a week and runs to the store and has a 10-minute drive and is back, right? And you could argue that if you spend half an hour a day driving, half an hour a day is only 2% of the total hours in a day, and the risk of seizures 15% in a fixed period of time. The risk of a seizure while driving is 2% of 15%. It's less than 1%. It's less than 0.5%. 0.3% chance of having a seizure while driving. A 0.6% even if you spend a full hour a day. So now the odds of having a seizure are well under 1%. If we're talking about statistics, we would say that wouldn't happen, right? If you're behind the wheel 8 hours a day, it's different. Now, in the United States, as of 2018, the last year I could get data, there were 6.3 million motor vehicle accidents in 218 licensed drivers, which is about a 3% risk on average, but it's probably higher because some drivers drive a lot, some hardly ever drive, and a lot of people have licenses and don't drive at all. Probably half the population of New York City has licenses and doesn't drive. A lot of older people maintain licenses but not drive. So the risk is 3% in general. If you're adding this 0.3% for the person who drives half an hour a day or 0.6 for one a day, the relative magnitude of risk is small. Let's contrast this to the teenager who's driving, and in the first year, I don't know how many of you remember your teenage years. I didn't have a poll. I would be curious to poll how many of us had accidents in our first year of driving. The statistics in the US are that 40% of people in their first year of driving have an accident, and the second year driver, it's a 37% risk. Now again, this is for teenagers. So we are in fact restricting people with epilepsy much more than we're restricting teenagers. So what do? I would think, number one, we don't really properly assess risk. The risk should be for the risk of not having a seizure, but for having a motor vehicle accident, and it's going to be different for different kinds of people. Is there a risk to long-term AED use? Yes. Bone health, cardiovascular, cognitive, and other, emotional. And I think we have to weigh not only the risk for people with epilepsy, but for society. So having somebody stop driving, there's the pedestrian and another driver that have to be considered. But I think we also should hold people with epilepsy to a comparable risk as other conditions. How much is tolerable, and what should we advise people? And I'm going to go to the end. So what do? I tell people, if they're driving a lot, they shouldn't go off drug. If they're not driving very much, they can do so. I tell them they should ideally limit their driving to relatively briefer time, to try to limit to less than an hour a day, ideally less than every day. Avoid high-speed driving. Take smaller roads with lower speeds. You're much less likely to be killed at 30 miles an hour than you are at 70 miles an hour. If you're ever in a car with another licensed driver, let that person do it. Combine trips. Don't drive to the supermarket and back, and then later that day you go to the drugstore, then later that day you go to the movies. Combine it so you're minimizing driving. Use public transport when you can. If you know that seizures tend to happen at a particular time of day, like they always happen in the afternoon, don't drive in the afternoon. If there's a seizure-provoking factor, don't do it. If you didn't get a good night's sleep, don't drive. If you had alcohol last night and you think that provokes seizures, don't drive. And how long the restriction? You can see it's a gradual reduction in statistics. There's no magic time. Now the interesting thing is, if a seizure happens after taper, the law in many states in the U.S. is that if you have a seizure in response to a doctor-prescribed change in medication, they will not restrict your privileges. So the states would say you can drive. In fact, the UK does not, because the risk of a second seizure in the first 6 months after a seizure from drug taper is about 45 or 46% also. So nearly half of people who have a seizure during taper will seize in the next 6 months or a year, I forget which now. A smarter vehicle is feasible to buy for some people, but they're not that smart yet, and this will really be the solution for all of us. Now, any final comments? I think what I should do is I'm going to relaunch the polling and ask you to poll again. Whoops, I'm in the wrong poll. And none of you should be saying 25%. But I launched the wrong poll. I was going to say how many would say yes or no. And I think I would say the correct answer is you don't advise him one way or the other. You advise him of his chances of relapse, of the restrictions, and he makes a decision that we offer no opinion whatsoever in this regard. And for those of you who think the odds of relapse are only 10%, we'll have this talk online. You can go back and look at the slide, but his odds of relapse are about 46%. So I think we're going to end now. It's just about 2:30. I want to thank everybody. Hope it was helpful. And the AES will come back with other speakers in following weeks. And good luck to everyone. Bye-bye.